Good evening, hello, welcome everyone. Thank you so much for joining us on your Monday evening. My name's Alison Burgess. I'm the manager of the primary healthcare team here at the Western Melbourne PHN, and thank you for joining us for part 3 of our COVID series, Managing COVID Positive Patients in Primary Care. Welcome back if this is your 3rd session, and welcome if you're a brand new person and it's the first session for you. We've got a really great session tonight and we'll get moving to that pretty quickly. Just before we continue, I want to make sure we take a moment to acknowledge the traditional owners of the lands on which we're meeting today and pay our respects to their elders past, present and emerging. As with all these sessions, we've got some housekeeping stuff that we need to get through before we can begin. So all of you are dialing in, you're currently on mute, and that will remain that way during the presentations. That just ensures we get the best audio quality as possible. But we do want you to communicate with us and engage with us this evening, because we've got actually a fair bit of time to do some really good question and answer sections with both of our speakers tonight, so really encourage you to do that. So the best ways to do that, we've got a couple of options. Tonight we're actually encouraging people, if you're keen, to actually put your hand up virtually, and we'll see that you've put your hand up when you want to ask a question, and then we'll let you know when we're ready for you and we'll get you unmuted and you can ask your question in person. So we're encouraging to do that. If you're more comfortable, there is a chat question box, which is in the it's like in the tool pane that you should see on your screen. Normally it sits on the right hand side of your screen, but it could be in different spots depending on how you're dialing in. So in that question box, you can type any of your questions that you have throughout the session, and we'll try to ask all of your questions where relevant as we go, or we might wait until the question and answer section. So put your questions in there throughout the session as you think of them. And now there's also a chat box that you'll see in your toolbar. So this is used if you have any questions or things that you have around maybe issues you're having hearing or seeing the screen. So we've got Madeline, who's behind the scenes for the PHN, doing all the admin side of things, making sure these sessions run really well. So Madeline will talk to you via that comment box if you have any of those specific things that you're struggling with. But for questions for our presenters, just make sure you put that in the questions box there. Post session, so post tonight's session, we will be sending out an email that has some of the links or different bits of information that are covered tonight, and we'll also have the usual evaluation survey. Now you're probably used to getting these with every education session that you attend, but we do highly encourage you to take a moment to complete that, because we really are basing the sessions, particularly these sessions around COVID that we're providing for our region, on a lot of the comments and feedback that you're providing us. So these sessions are designed with your input in mind about what you're really wanting to see and have covered in the COVID space. So those surveys either get sent out this evening or will normally be in your inbox tomorrow morning at the latest. Now, some more COVID specific stuff. We've run through this previously, but I always think it's great to recap for everybody. When you're thinking about COVID and all the really important work that you guys are doing, we've got the 5 S's of things to think about in terms of staying on top of all the information that's coming and changing in the COVID space. So if you're not already, making sure you're looking at the DHS website for all the quick reference guides. Point number 2, signing up for the PHN updates. We really recommend this, and we've been getting some really great feedback from our region, general practices within our region, about how useful these updates are. So these are e-blasts. So our team does a lot of work in taking all the information that's coming out from the DHHS and different sources, and really pulling it down into what's most important for general practice. What do you guys really need to know to stay on top of all the changes? And then we put those in those e-blasts that come out every day or every couple of days, depending on when this new information is being made available. So if you haven't signed up to our updates and you're not currently receiving those e-blasts, please let us know, and we can put you on there to make sure that you're getting those so you can read them regularly. The Chief Health Officer obviously have their normal alerts, so making sure you subscribe to those. They have the hotline number that still exists. And the last one, it's maybe something that you haven't quite thought about yet, health pathways. So there are the COVID-19 specific pathways that again are being regularly updated with any new changes that are happening as they happen. So that's a great place. If you're ever not sure, you need more information, you can jump onto health pathways to have a look at what's the next steps in the COVID management space. So you can actually set up an automatic login for that. So you don't need your username and your password each time you dial in or want to log in, and we can help you set up an automatic login. So again, just let us know, and you can do that following the session or via that feedback survey. We can actually get that set up for you. Some extra specific education sessions that we're organising or supporting around COVID. We're obviously running lots of different types of education, but we've got some real specific COVID stuff that you might be interested in that we wanted to mention for you tonight. So this coming Thursday, there's actually a session scheduled managing COVID positive patients within the Austin model. So the Austin Hospital has a model that they're using for their COVID positive patients. So if you think that you might have patients that are going to be working with, or not working with, but going through the Austin system, this might be relevant for you to dial into. On the 15th of September, there's actually 2 different sessions that might interest you. The Royal Melbourne Hospital is actually running a session around COVID and pregnancy, so looking at the risks of COVID and pregnancy, and also the changes that are happening in the antenatal care space. So again, that might be relevant to you with the patients that you're seeing. And then we've got another session that we're putting on, Build Your Skills in Telephone and Video Consulting, a webinar for doctors working in aged care. So specifically for GPs in our region that are having to help patients who are currently in the aged care setting. This is a really good chance to come on and learn some of those skills and have a really good practical engaging session and lots of question and answer time. So that one's also on Thursday the 15th of September. These are being recorded as well, so if you can't make all of them, we'll have the recordings available for you. And then another one that we're doing in this sort of series space is managing patients presenting with COVID-related mental health issues or mental health distress. So again, particularly looking at the GP space and what your role is and what kind of supports are available to you. And that's on the 22nd of September. So those, I think, are all live at the moment. If not, they're not all live for registering. They will be live soon, and we'll be letting you know when they're available. So looking forward to signing up to those. And I think I'm almost done. It's just my chance to introduce all the great speakers that we have tonight. So we've actually got 2 different speakers tonight, really great opportunity from both of these. So first up, we're going to have Dr. Catherine Orr. So Dr. Catherine Orr is with cohealth and is one of the general practitioners there, doing a huge amount of work in the COVID space. So she'll be updating us a little bit on the model, but also looking at some of the clinical stuff and looking at some cases and some question and answer time. Then we've got Associate Professor Lou Irving, who's from the Royal Melbourne Hospital. He's the Director of the Respiratory and Sleep Medicine section and Director of Clinical Training. So he's also going to be presenting a case for us and allowing a lot of question and answer time. We've also got 2 other members tonight who will sit, I guess, on our little question and answer panel. Dr. Alastair Miller, who's presented at our previous sessions. He gets a bit of a rest tonight and gets to come in and just help with some of the questions that you might have. So Alastair's a respiratory and sleep physician and has also been one of the clinical leads for the development of the COVID positive care pathway. And we also have Bianca Bell here again tonight. She's the Director of the Primary Healthcare Improvement Team here at the PHM and has been really heavily involved in getting everything set up in terms of how we at the PHN help support you in general practice, so I can answer some of those questions around our support and what we can provide and what we're doing at the moment. So I think that's enough for me. I think, Dr. Catherine, if you're ready to go, we can get your slides up and running first.
Hi everyone, I'm Catherine. I've been working for cohealth since April, doing all COVID basically response. Give me 1 second. Okay, so of course we've trialled this and now my slides aren't moving on. There we go. So I'm going to just do a quick update on the COVID care pilot and then present a couple of case studies. I also just want to thank Nicole Allard, a GP at cohealth, who has contributed to some of the slides. This is just an update on the Victorian numbers as of today, which I'm sure you've all been aware of. So an update on the COVID positive pathway. So it will expand to include Western Hospital catchment, and cohealth will work with local providers such as IPC for caring with COVID positive patients, and the primary health network will continue to work to link people with GPs in our region. And the department just at the moment has paused the GP approval for release from isolation just until it's just got some data reconciliation issues, and that hopefully will be reviewed on Wednesday, and we'll be able to go back to clearing patients. So this is just an update on the patients in each stream over time. So you can see the vast majority, there's a lot of discharges. There's a very small purple line for those that are inpatients discharged because of they're deceased, and you've got a large percentage that are the low risk cohort. So just having a look at the performance from the start of the pilot, the vast majority of patients are in the low risk stream, which are ideal for GP management. So this slide's a bit busy, but it's just basically, some of you will have seen this from Nicole's slides. You can see they go from testing to DHS notification to referral to cohealth and the consent to participate in an initial assessment by cohealth, and then put into low, medium or high risk streams. And as GPs, we're managing the low risk stream. So that's the 70%, approximately 70% of patients with mild symptoms and no particular risk factors. So just an update on COVID here. You can see that 85% of people can be managed in the community, 40% are asymptomatic, which we know it's more likely if they're young, 15% require hospitalisation and 5% ventilation. They're more likely to need hospital admission if their patients are older or have got other comorbidities. And there's some role for dexamethasone use. It's really a moving space, the treatment of COVID. So just some red flags in managing COVID. If you've got new or increasing shortness of breath, chest pain, syncope, altered mental state, weakness or lethargy, hemoptysis, which I've only seen in one patient, and consistently missing meals for more than one day. Then I just wanted to go into some case studies. I've managed probably more than 50 patients with COVID since the model came into existence. And these were two really interesting patients from my point of view. So, this was first case is a 31-year-old Korean international student. He had no Medicare, no income, no Centrelink. He's got private health insurance, but no money coming in. He lives with his partner and another couple, and all four of these people presented for testing on the 29th of July. So on the 26th of July, he developed sore throat and fever. It took him a couple of days to come and present for testing, and then 2 days later tested positive. The patient was notified and entered into the pathway and referred to me. The patient had been, the DHS were alerted of the positive test, and interestingly, it wasn't actually me who rang the Department of Health, it was a nurse, and when he rang the patient, he felt the patient was quite unwell. So he said to the Department of Health, this person's fairly urgent to follow up, because knew that he was living with three other housemates. So of the housemates, his intimate partner also tested positive. Of the other couple, one was positive and one was negative. So then on the 31st, which was day 5 of symptoms, his fever and sore throat had resolved, and he really only had loss of taste of smell and a bit of shortness of breath. We had the opportunity to deliver a pulse oximeter to him, so we delivered that, and he was reviewed that evening by myself, and his SATs were pretty good. He didn't desaturate with any challenge, but interestingly, he hadn't heard from DHHS yet. Then the next day, which was the first, day 6 of symptoms, he had increasing shortness of breath, and his cough was now quite frequent. He was unable to shower due to shortness of breath. He was eating and drinking well, and I had reviewed him in the morning and with a plan to review him again that evening. He still hadn't heard from DHHS by that day. Then on that evening when I rang him, he seemed quite unwell. He actually had a thermometer and taken his own temperature, and his fever was 39. He had cough and his shortness of breath were getting worse. He was now only saturating in 92%, and he was unable to speak even in short sentences due to frequent cough and shortness of breath. It was interesting because this fellow was one of the first patients of mine that seemed to get really unwell quite quickly over a matter of hours, really. And Having spoken to him over the phone, I was quite frightened for his well-being. His English was a second language, but he was reasonably good. We didn't need an interpreter. So I've called the ambulance, and I got a call back from one of the clinicians from Ambulance Victoria, and he said, no worries, we'll go in and assess him. And the ambulance attended. They didn't get back to me, but I got back to the patient about an hour later, and he said the ambulance had left and not taken him to hospital. So I was a little bit concerned because I felt like my assessment and the figures that we had on his observations, you know, to me felt like he was quite unwell. I actually spoke to Nicole Allard at the time, and we ummed and ahed about, you know, ringing the Royal Melbourne ED and trying to get an actual assessment, and, you know, sending him in by Uber or taxi. But in the end, we decided we'd review him first thing in the morning. He was well aware of, you know, needing to call an ambulance if he felt worse later on that night. Interestingly, the next morning, he was much better. So he was saturating, you know, significantly better. His cough was a lot less. He could talk in sentences, and Department of Health had finally got in touch for contact tracing and follow-up of symptoms. So he continued to just improve every day until he was discharged, and he met discharge criteria on day 14. So the second case study is a 24-year-old female Colombian international student, again with no Medicare, no job, no Centrelink, and had private health, and again had no income. She lived in a share house again with 3 other people. She did not speak adequate English, and so a Spanish interpreter was used the whole way through. And all 4 of the housemates were tested on the 5th of the 8th. So she had developed symptoms on the 4th of the 8th, developed a sore throat, presented the very next day for testing, and then 3 days later, a test came back positive. She was notified, it entered into the pathway, and referred to me. We also had the opportunity to deliver a SATS monitor to her. So we did. She was reviewed on the 9th of the 8th by telehealth with our nurse, and she was reportedly quite anxious. So none of her symptoms sounded very severe, and she, you know, sounded quite well over the phone, and her OBS and SATs and things were quite good. But the patient was anxious and wanted a doctor to see her. So we referred her back through the COVID team to the Royal Melbourne Hospital in the home, and contacted her that afternoon. I couldn't get hold of her, couldn't contact the patient or housemates, and so that situation was escalated via Royal Melbourne Hospital in the home. The next day, the 10th, so day 6 of symptoms, she was feeling reasonably well. She had some cough and shortness of breath and loss of appetite, taste and smell, but she was eating regularly. Royal Melbourne hadn't been in touch with her, but that morning the patient had said she had all these missed calls on her phone yesterday. So I did reinforce that, you know, it's important to answer your phone even if it's a unknown caller. So she was saturating 95%, and she wasn't desaturating with any challenge. So the plan was to review her the next day. The next day was day 7 of symptoms, and we'd actually been contacted via cohealth central number by her housemate because the patient had appeared to deteriorate overnight. She'd not been out of bed. She appeared to be very short of breath. The housemate described her as not being able to swallow her saliva. So I wasn't, and this was all through a Spanish interpreter, so a little bit tricky. So the housemate had contacted cohealth and requested an urgent assessment. So when I rang through to her, she had cough. She was afebrile and she was saturating 94% lying in bed. So there's myself on the phone talking to a TIS interpreter who's talking to the housemate on the phone and then talking to the patient. So it's not an ideal way to assess a patient, but it's what we had. Anyway, I'd said to her, well, let's get her out of bed and see what happens when she stands up and sits down a couple of times. And there was a lot of discussion back and forth, and then she got back to me that she couldn't get the patient, her housemate, to stand up at all. She was just sitting on the end of the bed and she'd desaturated to 84%. So we again called an ambulance category 1, and she was actually assessed by the paramedics and transported to the Royal Melbourne and went directly to intensive care. So, and then I followed her up on discharge. So she had spent 2 nights in intensive care. She was not intubated, and then the remainder on the ward. And she was feeling pretty well, with the only symptoms really being fatigue. So I just wanted to sort of bring these 2 patients up because they were fairly similar patients, one male, one female, and interesting, the male was that little bit older, but neither of them had any comorbidities or risk factors for deteriorating COVID. The saturations were really helpful, but particularly in the first patient, male patient, the face-to-face assessment by the paramedics was much more accurate. So they made the right call. He didn't need transporting, and he, the next day was significantly better. But I also just want to make the point about the importance of linking these people into GP care, because both of them fell through the cracks a little bit. The first patient in the Department of Health had, took about 3 or 4 days to get in touch with him. And I actually rang them to find out what had happened. And our notification to DHHS had gone to a Queensland call centre, and it was on the paper system back then, and it had taken 48 hours for him to appear on their computer, and the fact that he was quite unwell had been missed. And also the second patient, I'd sort of gone to bed thinking she was going to be escalated into hospital in the home, but for whatever reason that didn't happen. It's clearly not an RMH issue. The patient was uncontactable. I couldn't contact her either. But it was just important to demonstrate that there's another layer of care and another safety net for when patients get missed. And also I just wanted to make the point that international students are quite a vulnerable group, because they do have private health insurance, but they can't afford to pay up front. So for private GP appointments or for ambulance care, we had that second patient who called an ambulance. Her insurance actually were demanding that she pay the $1,500 ambulance bill up front, and then they would reimburse her, which she couldn't do. She didn't have any income, so she's got no money, and they're quite vulnerable. They can't get back home, and obviously getting a job in Melbourne, they're often working in casual employment that's not available at the moment. So that's my talk. I just wanted to put a little plug in for the cohealth West Melbourne Respiratory Clinic, which is situated at 98 Abbotsford Street, and that's where I work at the moment. And it's a testing site, but it's also a respiratory assessment clinic. So we can see patients with respiratory symptoms who might present for testing and can't see their GP face-to-face, so little kids with sore ears or sore throats or someone with worsening asthma. And, for the purpose of saving PPE, I'm happy to see them. We're always in full PPE, and we can do their swab and do a clinical assessment at the same time. And the other option is we can see COVID positive patients on site. So I would forward my details to the PHN if anyone wants. I can also be available for secondary consult for GPs who want to just chat about any patients they're managing where they just want a secondary bit of advice. So that's the end of my talk. Did anyone want to ask any questions?
Hi, Catherine. It's Bianca from the PHN. We've got a couple of questions that have come through. So Rob was asking whether there was video access to assess these patients, or was it only by telephone?
Yeah, that's a really good question, and I think we do have the option to assess by video, and I think that's really useful because it gives a face-to-face option. It's not quite the same as being in the room, but I think it's definitely a good option, and we do use it from time to time. In this setting, I elected not to, and happy to accept criticism for that. But yes, I think it's important to remember, and the PHN have got a link for setting up of the video consultation, which requires very little technology on the patient's behalf.
Yep, absolutely. That's the Health Direct system. There was a question / comment about obviously the two examples you've given were patients that weren't eligible for Medicare. So a question around how do we help these patients in the situation where they do have no money. Do you want to talk about how that's handled in the program currently?
Yeah, so cohealth has recognised that they're a vulnerable group, people without Medicare. So I've put my hand up to manage them, and we've just elected to forego any billing around that. And but that's very different in private general practice. So if you have patients referred to you that don't have Medicare, and a lot of them are very frightened of using their insurance because of out-of-pocket costs and having to pay up front, I'm very happy to take them on because cohealth's got capacity to do that.
Great. Thanks, Catherine. And certainly in our sort of the PHN support of the model, there are some practices that have stuck up their hand to take new patients on, but generally the ones without Medicare are being referred through to cohealth. We don't have it's not a question, but a comment. So certainly just a comment in relation to the sort of delay from DHHS. So with 5 positive patients, this particular GP, Gabrielle, was involved in, none had timely contact tracing and 1 was released by text message based on previous status as a close contact. She also later tested positive. So I think just to, there's a lot of frustration out there with the contact tracing and some of the delays that's causing for patients.
Yeah.
I've got another question here. Can a GP, and please feel free if I am not talking through your questions in an appropriate way, please feel free to put your hand up, and happy for you to ask them yourselves, that would be fine. Can a GP confident enough to discharge COVID positive after 14 days isolation and symptom free, can they be discharged from isolation and allowed to return to normal job without retesting? So a question around the need for a retest.
Yeah, so that's another really important role of the GP, is to clarify a lot of those questions, because a lot of patients want to retest. They really want to know that they're testing negative, but unfortunately the test can remain positive for weeks and weeks. We had one fellow from the Cedar Meats outbreak who, for some reason, was coming every week for a test. So he was positive initially, and his test was positive for 9 weeks. So it's not a helpful aspect of the discharge. And I try and say to patients, explain to them that the test is just picking up pieces of virus. And, you know, I'll talk about the clinical criteria for discharge, but this is what I say to them, that the test doesn't actually grow virus to see whether the virus is alive. It just picks up pieces of virus, and you may have bits of virus that's dead still floating around, but the test is positive. And the problem is, if you then get a positive test, you risk, you know, I would hope that DHS can see the sequence of events, but if they independently go and have a test, they'll, in all likelihood, at 2 weeks still test positive. So we've got to discourage people from having repeat tests despite their anxiety about it. So, you know, GP can clear the patient. The criteria is at least 10 days post-test or onset of symptoms, whichever is later, and they have to have a clear 72 hours prior of absolutely no symptoms at all. So we're under the pilot scheme, GPs do have permission to clear patients using that clinical criteria. But if patients want an official DHHS clearance, they can phone through and get that as well. Does that answer the question?
Can I just add to that? That's actually changed today. So there's been a retraction of that from DHHS.
Yes, in my initial form.
Only DHHS are allowed to release people as of today.
But that should be reviewed. So that's the last point there. They've just paused that until Wednesday, hopefully.
So that's just to be really clear, you certainly mentioned at the start, Catherine, that GPs can certainly discharge patients from the pilot, but the release from isolation is being taken back by DHHS until they review that on Wednesday, which is around certainly not an indication that anything has particularly gone wrong, but it's just about making sure that the public health unit can keep up with the data of who is and isn't in isolation. So there was a question around, is there an average time that people lose their sense of smell or taste? And is this a symptom that must subside for clearance?
I've found it quite variable, the loss of taste and smell. It's really frequent, and sometimes it's only there 24, 48 hours, but sometimes it's very persistent. I'm happy to be corrected, but my understanding is that if that's their only symptom and they've had 72 hours of no symptoms at all and they meet the discharge criteria otherwise, then I don't think that's considered a persisting symptom, because in some people it can persist for weeks and weeks.
Great, thank you. A couple more. So there was a patient in her 30s who was positive, wasn't unwell, normal saturations, but coughing at night, and asked for dexamethasone. Any advice for that, GP?
Yeah, so interestingly, the Colombian woman asked me for dexamethasone because that's what people were getting back in her home country. I think that needs to be done in coordination. It has been done by cohealth for a handful of people in the community, but only for very complex reasons, and needs to be done in coordination with the Royal Melbourne.
Thanks. So another question just around, is there consequence post-COVID infection with liver or renal impairment? Can a doctor request blood test or X-ray ultrasound without retesting for the virus?
I might hand that over to my Royal Melbourne colleague.
Look, there certainly are both liver and renal consequences of severe infection, but it's only tends to be seen in severe infection. And if people have been cleared, so if they've had official clearance post-infection from DHHS, there should be no impediment to them getting tested, at their normal pathology or radiology services, because they're not considered infectious at that point.
There's another question. Sorry if anyone can hear my dog in the background. Catherine, not sure if you want to take this one, but a question around, it's probably for the cohealth situation where you're taking on those non-Medicare eligible. Who's actually paying for the telephone interpreter in that case? Is that covered by cohealth?
Yeah, no, well, we've got a TIS account, so all doctors have access to TIS for interpreting, and that's regardless of whether the patient themselves has Medicare or not. So that's free, government funded.
There's just someone thanking you for looking after the patients who have been had international visitors with no private health insurance. So thank you for caring after them. And apparently St Vincent's Hospital also has a pathway that cares for this cohort of international students as well. There's a question around when a patient deteriorates, can the GP tell them to attend DD, or should an ambulance be called?
My feeling is an ambulance should be called, because if they attend DD, there's transport issues. So are you prepared to put a COVID positive person in a taxi or an Uber? And really, I think if you're managing them over telehealth, either phone or video, it's not an ideal assessment. And so the best thing really is to get the paramedics to assess them. And they're very experienced in Melbourne now, having seen loads of them. So you're going to get a really good quality assessment.
And personal cars are supposed to be furloughed for 72 hours after use for a COVID positive person. So shouldn't be using personal cars either.
Yep. As question, does anyone know where people can find, or do we have something in writing about not retesting? Is there something sort of in the guidelines that gives guidance around not needing to retest after a positive result?
Well, if you go through the red cap emails, so if you're a GP managing a patient through this pathway, you will be getting red cap emails reminding you to check in on the patient. And if you feel that they meet the discharge criteria, you can go through the points in the discharge survey, and it makes it very clear what the criteria are and whether they meet the criteria for release from isolation, which, as we've said, it can't be done just at the minute, but hopefully on Wednesday that'll be restored. So it's pretty clear that they're the guidelines. Are you wanting something to hand to the patient, or?
I'm not sure, Kylie, if you want to pop your hand up and put that, but it's just about, I think it's something about, for those patients who particularly are sort of, asking for that retest to see if they've been cleared. Is there any sort of guidance that can be shared?
Yeah, I've been asked a lot, and I think it's the same as the chlamydia. You wouldn't want to retest someone very quickly after treating them for chlamydia because their PCR would be positive. So, and I think everybody that I've explained to, I say to them, if you get a retest and you test positive, you might start this whole process again. And so that's when they say, oh, okay, because they actually really want release from isolation. So I say to them, these are the criteria, you meet the criteria, it's a Department of Health criteria, you'll get a certificate that says you're released, you don't need a retest. Everyone I've explained that to has been happy with that.
Great, thank you. And do housemates of patients that have symptoms but test negative in PCR need further tests, or just notify as clinically positive?
I don't notify them as clinically positive. I would suggest if you really have a high degree of suspicion, there's no harm in retesting. I know certainly in hospital for patients who appear to have, clinically COVID disease, they are tested more than once. So if you think clinically this is COVID, I would suggest sending them to a site that does a really high quality test. At West Melbourne, we're doing the saliva test and the nasopharyngeal swab. That's part of a trial, but I think I would be retesting if you've got clinical suspicion.
And there was a question about whether is retesting before discharge happening in hospital. Another comment was just that transfers back to residential aged care facilities have to have 2 negatives before they go back to residential aged care facilities.
Yeah, so this pathway is very much geared around patients who are in the community and being managed as low-risk patients by GPs. So in that pathway, you're not required to do a secondary test. So hospital discharge and transfer to aged care, I couldn't comment on. That criteria is going to be quite different.
And Catherine, sorry, this is probably just the last one before we introduce Lou, but if a patient was cleared and cleared from isolation and discharged from the pathway, but then later developed symptoms, do they get tested again?
Yes. So I think if you suspect that someone has been reinfected with COVID-19, you should be retesting them. I think there's certainly international evidence that people can be reinfected. That's all very unknown at the moment, and you can't assume that just because they had COVID 8 weeks ago, they haven't got it now.
And so just the final question before we move on to Lou, and there will be a chance for other questions after his presentation as well. The pathway states that GPs should not discharge COVID positive patients that will then have contact with immunosuppressed people, so they become a sort of, by definition, complex patient. And given that many COVID positive patients will be healthcare or aged care workers, can a GP discharge any of the healthcare workers? Again, discharge from the pilot will revisit the isolation issue.
Yeah, that's a good question. My understanding is that you can, yes, and if they are dealing with immunosuppressed patients, then I would imagine that in hospital you would be wearing appropriate PPE around those patients regardless. So the transmission risk should be reduced by universal precautions in that sense.
And if that's still in the pathway, it has been taken out in a subsequent revision. So if it still exists within the pathway on any documents, we will need to get that fixed up. So we will check that. Thank you.
We'll certainly check that from our end as well. There was just one quick question about the current. We talked about the video calling pilot. So with Health Direct at the moment, there's a question about whether that's extending beyond September. We have not yet heard from Health Direct about whether that's extending beyond September, and suspect that we won't hear about that until there's confirmation of hopefully extension to the COVID telehealth items. At the moment. And just to recap, there's just been a couple of questions clarifying the release from isolation. So the release from isolation that was in place up until today, that it was only for GPs that were participating in the COVID pathway pilot, because they actually stepped through the steps. So it wasn't something that was available to all GPs, is my understanding. Correct me if I'm wrong, Catherine. And that's on hold at the moment, but it was just for those GPs that had patients within the pilot.
That's correct.
Yeah, great. Alison, I might flip over to you to introduce Lou, who I believe is online now.
Yes, that's right. So our second speaker for tonight, as I mentioned earlier, is Associate Professor Lou Irving from the Royal Melbourne Hospital. He's a Director of Respiratory and Sleep Medicine and a Director of Clinical Training, and he's also got a case to share with us this evening, and will be available for some question and answer time. So Dr. Lou's been pretty busy already presenting somewhere else, I think, tonight. So we're lucky to have him on board, and we'll just get Lou up and running.
Good evening. Are you able to hear me?
Yes, all good.
This is just a quick presentation. It was part of a grand round from a couple of weeks ago, and there was a co-presenter, Alex Holmes, who's a very talented liaison psychiatrist, and I'll be really raising issues rather than answering questions. And under that heading, you know, a lot of what is raised is highly speculative, and we need to remember that we're talking about symptoms, and I'm not going to ascribe biological or psychological diagnoses. And I'm also conscious that there may be people in the audience who've been directly or indirectly affected by COVID, and I hope this doesn't distress them. Just to remind you that it's a predominantly adult infection. Fever occurs at some point in the infection, but often only in a minority at the beginning. Other common symptoms are a non-productive cough and breathlessness. And most importantly, that, you know, as you're very aware, 80% of cases are managed at home. So people like myself who work, and Al, who work in hospitals, really see just one small aspect of COVID. It might be different for post-COVID. For people who come into hospital, the pathophysiology is a bilateral pneumonitis that tends to be peripheral, and you'd swear it was organising pneumonia if this time last year, before COVID occurs. And a small number of these patients develop a full-blown ARDS with a tendency for gravity-dependent consolidation, but, you know, also for ground glass inflammatory changes that then heal with bifibrosis, even in non-dependent areas, for the people who survive. The extrapolating from influenza and also what we know about ARDS, you know, very severe consequences of post-COVID effects could include lung scarring, and so this process in 3 months' time will be scar tissue, and then in 6 months' time there'll be a bit less scar tissue, and in 12 months' time there may be even less. So it's not like progressive idiopathic pulmonary fibrosis. With COVID, it's postulated that there might be pulmonary vascular effects, including microthrombi and aberrant vasoconstriction related to hypoxic or low ventilation. A cardiomyopathy has been described post-COVID. Peripheral myopathy, is not uncommon in people who come out of ICU with lungs like that, but it's also been postulated that post-COVID there might be an inflammatory myopathy, and there may be some evidence for post-COVID CNS disease. That's what we know at the moment, but none of this is well characterised, and some of it is inferred from previous severe respiratory viruses such as SARS and influenza. The case is a young professional who living with a husband and 2 children, one of whom's disabled, and she had a past history of short bursts of atrial tachycardia, gastritis, really nothing else of significance. And in July, she presented to ED with some non-specific GI symptoms and fever, and the nasal swab at that point was negative, but a few days later, because of persistent fever and a burning throat and chest tightness, she represented, and at that stage her COVID was positive, and she had this reasonably obvious infiltrate at the right lower lobe and maybe a little bit on the left, but it was more asymmetric than usual. In the second week, she had persisting sweats and mild diarrhea. She wasn't admitted, by the way, and wasn't hypoxic. And from about the second to third week on, she started developing a significant sleep disturbance, regular waking with palpitations at night, mild fatigue. And in the third and fourth weeks, her acute infective symptoms settled, but they were replaced by a very significant sleep disturbance, waking every hour with palpitations, and she became housebound and mostly bedbound during the day because of fatigue, and she complained of not being able to do anything. She was seen by her family physician throughout this time, and he was unable to find any abnormal clinical findings. Blood tests were essentially normal, and because of the past history of paroxysmal atrial tachycardia, he arranged a Holter monitor that essentially was normal, and he recognised that there may have been a significant mood change and commenced low-dose Lexapro and prescribed sedatives to help restore sleep rhythm at night, although the patient wasn't compliant with those. I saw the patient as a sort of a second opinion, and I think this might be a relatively common pathway, particularly to look for any physical abnormalities. And the history I got at that stage, which was at about 4 weeks after the infection, that she was able to get to sleep quickly, but she was waking every hour or so with palpitations. There was no chest pain. She had the same pattern throughout the night, and there was no suggestion of sleep disordered breathing. And when she woke in the morning, she didn't feel refreshed, and she hadn't really used the temazepam regularly. The fatigue was as described, and there was no associated muscle or joint pain, mouth ulcers or rash, no postural dizziness, no palpitations during the day, chest pain or shortness of breath with exercise. When I asked her about the mood, she admitted that she was stressed. Interestingly, she'd been isolated in the hotel as part of her illness because of her young family, and she found this a major trauma, and it might be a recurring theme that you've come across. Life at home had become very dysfunctional because of a number of factors, and towards the end of the consultation she indicated that she thought she was going to die, and she said that if she didn't die she was definitely going to get chronic fatigue syndrome, and she'd already been exploring the possibility by looking up information on the web. She had some other interesting symptoms. She was thirsty, dry mouth, and said she couldn't cry. She was mildly anorexic, but her smell and taste were okay. And examination, I couldn't find anything specific. She looked very anxious and she was tearful when describing her feelings. And I do a sort of a 6-minute walk test as a triage or functional test in this setting, and she was only able to walk for 3 minutes. She covered 150 metres, and people in the audience will be aware that the average healthy adult will walk about 600 metres in six minutes. So that's, because 6 minutes is a tenth of an hour, that's 6 kilometres an hour. The patient's not allowed to run. So that between 500 and 600 metres in 6 minutes. And so she didn't get anywhere near that, stopped because of exhaustion, but did not desaturate, indicating that gas exchange and the pulmonary circulation were likely intact. And her heart rate was not abnormally high, which is different from a number of post-COVID patients that we've seen. And I repeated her chest X-ray on the same day, and that abnormality, particularly at the right face, had cleared. And so I had the same feeling that her family physician had, that there was a severe sleep disturbance, an acute mood disorder, and that these were associated with and possibly contributing to the daytime fatigue. And I didn't want to ascribe any mechanisms, but I couldn't find an obvious physical disorder on a quick sort of first pass clinical review. Because of the sleep disturbance, I ordered a sleep study, which I was able to get quickly. To improve her sleep, I asked her to expose herself to sunlight in the afternoon and do as much exercise, at least a little exercise in the late afternoon. I commenced her on a regular cocktail of melatonin, Imovane, and then Phenergan for breakthrough. And I had a sort of a plan where I cycle people through these interventions along with a benzodiazepam on a sort of a 2-weekly process until sleep rhythms are restored. I increased Lexapro. I spoke with the GP about getting specialist psychiatric assessment, and I decided I'd discuss this case with colleagues. As part of the sleep study, at Royal Melbourne, we routinely do an anxiety depression symptom score, and she ranked highly on both HADS A and HADS D, confirming the clinical impression of a mood disorder. And the sleep study was otherwise normal, except this relatively non-specific abnormality of increased alpha intrusions, which can occur in people with chronic fatigue, but can occur in other settings. And after a week of all the drugs that she was taking, her sleep was more consolidated. She was calmer during the day, but she was still mostly bedbound. And 2 weeks further on, there has been some improvement. I saw her face to face last week, and she's able to walk about 100 metres more, but can still not walk 6 minutes non-stop. And I sort of put my toe in the water to do a couple of more physical tests with some trepidation, and so far they're normal. So that's the case. I do have the sort of the presentation that the liaison psychiatrist had prepared, and I might just in 2 minutes, I'm not expert, but I'd just like to make his points that he was making the point that with other viral illnesses, there are psychological conditions that can occur, and these have been described in SARS and MERS, and that chronic fatigue is not uncommon in SARS, and that with other viral epidemics, including influenza and SARS, constructs have been made to explain symptoms that include biological mechanisms, psychological mechanisms, and sociological mechanisms. And Alex, who's, as I mentioned, an excellent liaison psychiatrist, was keeping a very open mind about the use of any of these constructs for what we might come across in a time of post-COVID infection. I'm not sure if I can get to the next slide. It doesn't look as though I can. So I might stop. Sorry. Yeah, Alex made a final comment, and that is that we really need to look at these symptoms from a patient perspective and be very careful about ascribing, our own perspective. And then finally, I just remind you of encephalitis lethargica, which was this sort of epidemic that spread across Europe and then the rest of the world and affected about 1 million people from around the time of the First World War through to the 1930s. And it started as a flu-like illness, and it was associated with flu, but the exact mechanisms were unclear, and it's still described as a mystery, and possibly the biggest medical mystery of the 20th century. I'll stop there, and I know we're almost at the end of the session, but if there are any questions or comments, please, I'd love to hear them.
Lou, thanks for your presentation. Bianca here from the PHN. We just had one question about that case. The GP was keen to know what was the patient's age and BMI? The case you just discussed.
She's in her mid-30s, and her BMI is around 30, 33. She's slightly overweight. It doesn't have diabetes. And I'm sure the audience were asking the question that I didn't ask, but I think she probably does, in her past history, also have some other psychological traumas.
Great, thanks. And there was just a question around whether any, you just answered that. You think that there was some previous mental disorders or issues with this patient?
There's been stress in her life in the past, because interestingly, the next case I saw, that was very similar, again with significant fatigue, but without the acute change in mood. The person psychologically was very robust, but still had significant fatigue and had a reduced 6-minute walk without any undue heart rate response or desaturation. So I think there's a spectrum, and I'm really wary about saying, that this is post-traumatic stress, or this is chronic fatigue, or this is, an undiagnosed cardiomyopathy. There may be any of those mechanisms.
Great. So does anyone, that's all the questions we've got. Just opening it up, that obviously we've got Catherine, the GP, did the first presentation. We've also got Alistair from Royal Melbourne. So feel free to send through your questions. We do have one question from Janelle. Any particular patient cohorts that you didn't expect to be worried about, but now are sort of presenting with more severe symptoms. So that's one for the whole panel. Alistair or Catherine, have you got any you want to add to that? So any particular patient cohorts that you didn't think would be sort of worried about with COVID, but are now presenting with more severe symptoms?
I can certainly, I see all the ICU patients at Royal Melbourne with COVID, and I don't think any of them have been of normal weight. Probably only 2 have not had diabetes. Certainly diabetes and obesity are very significant risk factors for severe disease. Al's been on the ward. It'd be interesting in his view.
Yeah, look, I don't think there is anyone particularly. I mean, I think we have seen a spattering of younger people. I think there was some concern about asthma, but I don't think it's necessarily been borne out. Certainly in some larger data sets from the UK, asthma hasn't come up as a significant risk. So I think, I think it's the known risk factors. I think we're still really waiting in terms of people post-COVID in terms of their symptom burden. There's certainly some data suggesting that young people, still have persistent symptoms and aren't back to their usual selves weeks afterwards. But I don't think we know for certain as yet.
Great. And Catherine, did you? Oh, sorry.
No, I agree entirely. I mean, I obviously don't see the very sick end, but there is I just would remind people that there is the odd young person that deteriorates, and they seem to deteriorate quite quickly. So if you need to do a morning and evening assessment of them, I would recommend it. It's no fun going to bed as a GP worrying about a patient overnight. So yeah, and if they seem to head downhill, that seems to happen fairly quickly, and don't discount that if they don't have any particular risk factors.
Great. I think a couple of people have their hands up. Kylie, if you've got your hand up, I'm just going to get Madeline to unmute you now if you want to ask your question. Sometimes hands go up by mistake. It's like it might have gone down now.
Yeah, yeah.
No problem, sorry. So there's a question around, for all the presenters, have you had the opportunity to refresh your PPE application and removal technique as a group prior to working in COVID positive environments? So is that things that have happened either at the practice or at the hospital? Donning and doffing practice?
Well, certainly been lucky. We've had good supplies of PPE and very good support right from the top about appropriate use of PPE at all times, and we've had regular updates on donning and doffing. So I feel I've been quite well supported.
Great. We do have a question about PPE. Can it be used all day, or do you need to change between patients?
At the testing clinic, we wear it for a session and change at lunchtime. If we assess a COVID positive patient, known COVID positive patient, we change PPE.
So this is a question probably for the Royal Melbourne panellists. Just sort of how stretched were the hospitals during the second wave, and a bit of a crystal ball question, how many active patients do you think it would take to swamp Victoria's hospitals?
I can talk for Royal Park. You're probably aware that there was an outbreak there that really showed some lessons learned, and luckily these lessons are being written up so that other people can be aware of them. But Royal Park had capacity for about 100 to 150 patients, and in old wards, and they were a combination of nursing home patients and rehab patients. And at the beginning of the second wave, some infected patients were brought in from outside nursing homes, and for a number of reasons, infection started to spread, and that occurred in spite of adequate staff training, adequate PPE, and it got to a stage where not only were almost all the patients positive, and there was a significant mortality, but a large number of staff were also infected, and though the staff included people who weren't even working in the wards, so chefs, medical records, admin nurses working outside the ward. It was very, very distressing. And we, in looking at different factors, we believe that the type of patients, so elderly patients who are often disorientated, who may wander, who require a lot of physical contact by nurses, who can generate aerosols just by calling out or shouting. So that's one factor. A second factor was that the wards were built in the time of Dickens, and we've demonstrated that in some of them the ventilation was very poor. So this concept of adequate engineering controls, which we're now extending to areas of rural Melbourne as well, and something that's being actively researched. And then I think a third realisation was that if there is a large amount of COVID in a relatively small space, it's very hard to particularly doff without becoming contaminated. Al, you worked on the COVID ward at Royal Melbourne. I'll be interested in your views as well, because we have actually had outbreaks in our COVID ward at Royal Melbourne. The final thing I'd mention is staff fatigue. It's very, very hard, particularly for nurses, to work long periods of time in PPE, and because we had so many people unwell or furloughed because of contact tracing, the staff who were working were often working for 7, 8, 9 days in a row. But Al, I'd be interested in your comments.
Yeah, look, I think we learnt heaps about just all of those issues. I mean, I think the question about how stretched the health service or hospitals were as a whole. I think we were lucky in some way that it was quite isolated, at least to start with. It's certainly spread out now. But I think if we had the intensity of infection throughout Melbourne that we had on the Royal Melbourne at its peak, I think the hospital system will have been pretty close to capacity, and that's largely around staffing. As Lou said, there were lots of people out furloughed or infected, and that it just meant that replacing those staff was really very challenging. So we had multiple further levels of COVID inpatient wards planned. But fortunately didn't have to go to those, but staffing them will have been the main issue rather than the physical space. So I think for future waves, I think I would hope that the issues we had with staff outbreaks would be much less, and so the issues with staff infections and the need to furlough large numbers of staff would be significantly reduced. But I don't know. I mean, we were planning initially for ICU numbers of over 100 just at the Royal Melbourne. So I think there is capacity to go much higher than we did, but I think the staffing would be the most crucial issue.
Yes,
Thanks,
I think the
Alistair.
maximum number of ICU patients was around 10, maybe 12, but and at the moment we've got 2. So we did dodge a bullet, I think.
There's a couple of questions that have come through, which are about testing for, PP mask fitting for general practices. So we're happy to take that on at the PHN. I'm not aware of what services, but just saying that some of the, it's GPs are suggested to go for mask testing, so fit testing. So we'll happily take that up at the PHN and be able to send something out if we hear about that. There is a question around, I'm not sure anyone on the panel can answer this, but I'll throw it to you. Do you think contact tracing is better now?
I can talk about that a little bit if you like, because I've spent a lot of time ringing positive people either at the time of giving them the result, but also to manage them out of the COVID pathway. It was pretty terrible at the beginning, but I think it has improved a lot. The patients, all the COVID positive patients that I have rung recently, they have been contacted within about 4 to 5 days of having their test. And often, in fact, the delay is more around getting the test result and then getting the test result to appear on DHS's computer. Once it's on their computer, they seem to be getting in touch with everybody within 24 to 48 hours.
Thanks for that, Kat.
Yeah, I don't know. I rang up all our infected healthcare workers, and it interested me that, and that was as soon as we knew the test, and that was from the Royal Melbourne Laboratory, swabs taken in the staff clinic, and we always got the results back within around 12 hours. And it interested me the number of times that the healthcare worker was just about to come, was living with someone who was, also a healthcare worker and was just about to go to work or was at work, or and I think if you waited a couple of days before you had contact tracing, certainly with certain groups of people, and it probably applies for workers in aged care, there'd be a lot of potential for further spread. I think we probably need it to be as quick as possible, contact tracing.
I think the improvement's only in the last, I'd say, 2 weeks.
Yeah.
Before that, it was pretty hopeless. I agree.
Yeah, I mean, if we're being honest, I think it's been pretty poor. To be fair, the health department have been under enormous pressure. But I think it's really important to remember that our public health branch of the health department was the poorest, sourced of all the states before the epidemic.
Yeah, and having worked on the border, I used to work in Albury-Wodonga. The New South Wales public health units are much, they're regionally based, so it's not a central call centre. So it was a much more efficient system, and people knew, if you worked at Corowa, the GPs there also managed the Rutherglen clinic over the border. So the public health unit really were on the ground. They knew their team. They know the GPs, they know the community health services, so they just act much more quickly, not just in contact tracing, but in cluster outbreak management. And I think that's probably reflected in the different scenarios across New South Wales versus Victoria.
I mean, as a professional group, once this is all settled down, I think we all need to advocate for stronger public health. And I know personally I need to pay a much more attention to infection control issues. I reflect that it used to be the realm of nurses rather, but doctors also need to take responsibility for it as well. it might be different in general practice.
So just a question for you, Catherine. What brand of P2 mask are you wearing when you're in clinic, and have you been fit tested for that?
I haven't been fit tested, and I've used a variety of masks because it depends on what PPE we can get in and what particular site I'm working at.
Mm-hmm.
And we've got those blue-green 3M masks at the moment, which I actually find really uncomfortable, and I struggle to wear them for 3 hours. And I have a pretty marked, ugly-looking face at the end of it. So I would be really grateful for fit testing, because I don't think that one's a great fit for me at the minute. So yeah, thanks if the PHN could take that on.
Mm-hmm. Great. Just a question. This is from Terence. I've heard a seaweed nasal spray can be as protective as a mask, about 70%, i.e. flow travel nasal spray. Any thoughts on this?
Hands up who breathes through their nose. You know, at least 50% of people breathe more through their mouth than their nose.
Certainly for a deep breath, I think most of us breathe through our mouth, so I wouldn't be relying on that.
Just having a look at any of the final, oops, move my screen. Any of the final questions? There's just a couple of comments, I think, finishing on, Lou, your comments around sort of, you know, public health. So someone just commenting that can't believe this has happened in a country with fantastic healthcare. It's quite scary. How do we get GPs to get more involved? And I guess just to follow on from that, sort of let's advocate for fully funded public health better than other states. And, you know, people talking about, you know, the government funded my Masters of Public Health degree and never called for my assistance. What a waste of money. I work with public health physician and also never called to assist, and people were very willing. So, you know, what's the panel's sort of suggestion as to how GPs could get more involved in these responses? Certainly the PHN is advocating at all levels for that to be the case, but is there any sort of practical suggestions any of the panel wants to give us on how we can continue to advocate for that?
The comment about the model in New South Wales being, you know, regional, I think that, you know, GPs could help with that, couldn't they? Because they could be part of the public health team in regional centres, and maybe, you know, to advocate for that to be in suburbs as well. I mean, it's not as though COVID's the only public health risk. I mean, there are all, you know, all the other respiratory viruses. There's gastroenteritis and so on. There's thunderstorm asthma. There are the risks of, you know, the greatest risk going forward is actually of poor air quality, both traffic and other forms of pollution.
I think at the end of it, the Victorian model needs a real overhaul, and I think we should be advocating for better funding as GPs through, you know, our professional bodies, whether that's the RACGP or AMA, and you have to, it actually has a unique model, so it's the only one that has 88 separate departments all centred around hospitals, whereas the Queensland and New South Wales have got and every other state and territory got a very more regional based model that includes GPs and community health. And I think that's the key, is that when we have an outbreak like this, it's not just hospitals that need to be involved. You know, geez, we're the ones who know our patients. We can certainly contact trace faster than the department can. And community health, community nurses, they are the people that know the linkages on the ground. And I think that's why New South Wales moves so much faster with their little spot fires than Victoria is. So I think we need to be, you know, asking for a rejig and an improvement on the structure of DHS, not just the funding, to include GPs and people on the ground who know our patients and our health linkages better than anyone else.
Yeah, I completely agree, Catherine. I think having a hospital-centric kind of service doesn't make any sense when, you know, we clearly don't know the community like GPs do.
Okay, so that looks like that's the end of the questions. I just want to thank the panel. So Catherine and Lou, it was really interesting to sort of see some of the cases and the everyday sorts of things that are popping up for you in terms of management. So we've had another great response to the session tonight. Alistair, thank you for helping out with the questions, but a really informative session. I will hand over to Alison to finish us off. Thank you all for your questions also.
Thanks, Bianca. And just quickly, I think, Catherine, you had offered earlier in the session for your details to GPs who might want to refer their patients to West Melbourne or would like a secondary GP consult. We can either provide you details now or we can email them out as part of the post-course.
I can do both. I've just got a slide that I'm meant to present that's just got my details on if you want to share my screen.
Sure, I think we can get Madeline to get that organised. I think she'll just need to give you access to do that. We can just put that up in case any of you dialing in would like to write those down, but we can include those as well. Yep, so we got those on there. So that's correct. Is it, Catherine, in terms of if you want to refer patients or if they want that secondary GP consult with you?
Yeah, that's fine. So just email through to that or give me a ring during the day anytime. I'm happy to take a phone call anytime during the day and just give you quick advice if that's helpful.
Great. Okay, so thank you so much, everyone, for joining us tonight. As mentioned, if you missed the very start of this session, there are some additional COVID-related sessions coming up in the coming weeks. One around COVID and pregnancy, one around if you're a GP working in aged care, if you're wanting to build your skills in telephone and video consulting, we've got a session for that, and also one around managing patients who are presenting to you with COVID-related mental health distress or mental health issues. So they're coming and we'll give you some information about when and how you can register for those. But thank you so much for joining us. We hope you have enjoyed the evening and we'll keep you posted about future sessions. Thank you.